Okay, thanks again to everyone. So we're going to launch our next session, which is data-driven innovations for health emergencies. What's missing? What's next? So this session will examine how data and innovation can strengthen preparedness for future public health emergencies by harnessing data through modeling and through innovative solutions. We're going to focus on what's missing and what comes next, and we'll aim to highlight opportunities to build a more resilient, data-ready health security and health system landscape. So I'm going to start by introducing Dr. Alison Hill, who is an assistant professor in the Department of Ecology and Evolutionary Biology. Her research group develops mathematical models of infectious disease dynamics and the evolution within patients and across populations. The goal of this work is guiding intervention strategies. So welcome, Alison.
All right, hi everyone. Thanks, Fahad, for the introduction, and thanks so much to Ted and Nelson for the invitation to talk here today. So today I'm going to be talking about model-based prediction and policy evaluation for the next pandemic. What data do we need? And just as you know, some background about me, I'm a practicing modeler. I've been doing infectious disease modeling around 15 years. Worked a lot on HIV, other kind of persistent viruses and drug-resistant infections before, like many of you being swept up into the COVID world about 6 years ago. And so I spent much of the last 5 or 6 years being really involved in developing models across scales to try to guide interventions for COVID and better understand transmission. I only recently moved to U of T. I worked for the past 5 years before that at Johns Hopkins, so my perspective on this, while some of it is coming from sort of the field as a whole, but of course will be colored by my particular experiences, which were outside of Canada. So this invitation really caused me, in a good way, to reflect on if we have another outbreak of this scale, would we really be any better in terms of making models that were effective and well received at guiding policy? And I think that's a difficult question, and today I hope to kind of get at some aspects of that, in particular the connection between models and data. So I think that models really contributed to many of our most successful COVID interventions, and that as a member of this field, I'm proud of that. I really think that early on in the pandemic, the idea of flattening the curve, while that's a catchy phrase, but the idea that this came from models and was backed by it was really, in my perception, something that helped motivate the public to make really dramatic behavioral changes that had a big impact on disease control. And I think a lot of other policies throughout in terms of the importance of frequent testing and reducing transmission, understanding the potential impact of widespread vaccination and the benefit of prioritizing certain risk groups, characterizing the sort of phenotypes of emerging variants. I think all of those things were key insights that models really allowed us to achieve. But at the same time, I think models were also involved in some of the kind of bigger kind of controversies or aspects of COVID that have had this like long tail of sort of more negative public perceptions of the field as a whole. So I think for some reasons that I'll get into, of course, early models had a lot of limitations and assumptions and problems with the data that we used to them, and I think that the public perception is that models really overestimated the potential burden of COVID along some lines, and that perhaps some people feel they were misled by that. It's very difficult with the data we had to accurately estimate infection fatality risks early on. I think that there was a lack of information and a lack of transparency in models in the degree to which we understood how much vaccines prevented infection and transmission versus preventing severe disease symptoms, and that this could be related to one small part of the sort of change in attitudes towards vaccines that we're seeing. And also, of course, there were some negative consequences of some of the policies that models were seen as advocating for, perhaps most notably school closures, and that Sort of one side effect of that is some less positive thoughts towards models overall. So I really think that we do need to think about how to make models better for multiple reasons, the technical and the broader impact. So, back to this question, in the next pandemic, firstly, will modeling have the same role? Will we be invited to be involved in many of these really important decisions? Will we be trusted to inform those decisions? And what could we do better? So there's lots of ways we could talk about making models better. I will not get into how we can have better math and better computational power, and I will not talk about how we can train modelers better. It's all things I'm passionate about, but today I'm going to focus, given the sort of theme of this part of the symposium, on the data needs. So what data do we really need to make models better? So kind of the bread and butter data that you're familiar with that goes into most of the infectious disease kind of projection models, of course, that you've seen are really measures of disease burden. So cases, deaths, hospitalizations. These are the things we want to be the target of our predictions, so of course we need to have them to go into models. And I think during COVID, a lot of people got really excited because for the first-ish time, we really had sort of large-scale public access to a lot of data like this across scales. And that's good. We do need this data. Many models, I think, to this day are surviving kind of on only this data, but even if we had perfect access to this, which we don't, many of these resources, and the ones you can see here, have now disappeared. The problem is that if we think this is all the data we need, we run into a lot of problems. So we really need to think about what are the other types of data that truly allow us to improve models of infectious disease dynamics. So one of the most sort of first order improvements that we need is really better spatial and demographic resolution of these important infection metrics. Now, of course, we all know that infection risk differs dramatically across groups, whether those are geographic groups, racial ethnic groups, age groups, and that this can be at a lot of different spatial scales. We can see variation. So we really need to be able to have data if we want to predict who is more at risk, what will happen if we intervene in those risk groups. We really need to have data at that level, and we need it in a connected way. As we talked about earlier, we have a lot of issues in Canada about sort of data exchange between regions, and that's a big barrier to infectious disease modeling, sort of treating regions as separate that are not separate, or pooling regions together that really have a lot of heterogeneity in dynamics. Another big problem is that any metric of disease, sort of disease burden, that is based on something reported, like cases or hospitalizations, no matter what the spatial and demographic resolution, still has inherent biases in it that do limit our ability to really understand disease dynamics and therefore predict them. So things like changes in reporting based on case definitions or procedures, changes in availability of tests, care-seeking behavior, relationships between infection and symptom severity, all of these impact these metrics and make it not kind of a constant proportionality factor between those metrics and the true infection burden. And that is something I think that's not talked about enough. It makes models really inaccurate, in my opinion. So things like the type of consequences this has in models are like confounding and not separating something like a case fatality ratio and an infection fatality risk. For all the epi nerds out there, like different quantities that making predictions with one versus the other leads to big differences in what you predict the potential sort of counterfactual disease burden would be in the absence of an intervention, and therefore the impact of your intervention. This can lead to biases in our understanding of age distribution of infection and roles of different age groups, and overall just suboptimal policy recommendations, which that's compromising the main goal, from my point of view, of a lot of this modeling we're doing. So one of the solutions to this, or the main solution, is really to find ways to measure disease burden in a non-biased way. So there's lots of different ways of thinking about this. Certainly during COVID, one of the nice ways that I think Canada did quite a good job at is measuring seroprevalence of infection based on blood samples that were collected for other purposes. It is unfortunate that this is not really still going on. Will we be able to roll this out quickly in terms of another outbreak? Unclear, but certainly measures serosurveillance systems overall can be super useful for this. There are other ways other than using like blood donor data you could potentially get this. There are now, for example, devices that people can do home, like totally painless self-collected blood samples. So thinking about how do we set up surveys to measure, not just seroprevalence, but perhaps like actual, point prevalence of true infection in individuals. There's also this diagram here is a picture of VeerScan. It's an example of like a multiplexed infection surveillance tool that also could be used at a broad scale to survey infection prevalences. Wastewater data is one example of an existing system that does kind of give you some overall measure of infection prevalence that isn't biased in the same way by disease reporting. There's a lot of other complications, of course, with wastewater surveillance and what does it actually mean, but these type of measures, think about how can we get truly like random samples to understand disease burden and how it varies across groups, are really, really important for anchoring models. Another really important thing I think we need to think more about is that much of the data that I think we need to make good models, it's not data that we can just passively collect. We need to design purpose-driven studies to measure key epidemiological quantities that are then what go into models and can be used for prediction. And we need to have studies set up in advance of the next outbreak that are ready to collect this type of data. So as an example, things I think that we still don't really know the answers to for COVID after so many years is, what role do children play in transmission? I don't think we have a great answer for that. Can we reduce the chance of needing to close schools in the future? How can we protect residents of long-term care facilities? To what degree was COVID transmitted among healthcare workers or patients? These are all important questions that can only be understood by really having carefully designed cohorts where transmission can be observed carefully. And those type of studies also allow us to isolate other quantities in more controlled environments. For example, household studies are a really well-known tool in epidemiology that can allow you to really estimate secondary attack rates of infection and how risks vary, for example, by age, or by kind of prior disease susceptibility. So we are lucky that actually in Toronto, there's an amazing study going on. Hopefully many of you know about Run Out of Sick Kids, where they are surveying diseases for the last sort of 4 years in dozens of elementary schools around Toronto, for example. And so this is all set up. If there's another outbreak of something new, they will be able to catch it. And in the meantime, they're using that information for really valuable kind of calibration of epidemiological models. We need to also understand kind of human behavioral aspects of disease. One of those is understanding how people are actually interacting and what type of contacts, how do we measure the contacts that are relevant for disease transmission. This can be at different levels, for example, contacts between different age groups, between people occurring in different settings in their everyday life, or between different geographical regions. You sort of may or may not know how people currently try to pull these numbers into infectious disease models. A lot of them are based on data from other countries or kind of crude estimates from censuses that are not meant to measure this at all. It's a big problem. This data is especially lacking for young children, who we know are really important for transmitting many infections and the target of many interventions. So this is a big area where we also need kind of purpose design the studies and kind of non-conventional data collection mechanisms to better pull these numbers into models. As was alluded to earlier, often the goal of models is to predict or inform vaccination campaigns or decide on vaccine allocation. This is really hard to do when we don't have great databases for understanding who is vaccinated, when are they getting vaccinated, what are our gaps in vaccination, and would we have this information in real time for emerging outbreaks. Another big gap on a different side but related to vaccination is that current vaccine trials, clinical trials, are not designed to measure the impact of vaccines on infection and transmission. They tend to only measure their ability to reduce severe outcomes of disease. This means that we don't have key information we need to go into models that help us estimate population-level impact of vaccination, and consequently, there's a huge amount of uncertainty in the impact of vaccination campaigns. And this is something, it's not just relevant to outbreaks. For example, we have new RSV vaccines. We don't know this information about them, and it's very difficult to make predictions about their impact. And for example, Canada and the US have come to very different conclusions about the degree to which those vaccines should be given to the general public because they are making different assumptions in their models. And then finally, as was also alluded to by Howard earlier, infectious diseases don't operate in a vacuum. Human behavior is such a big part of how diseases spread and how people respond to them. And it's also, one of the main sources of criticism around models, I think, relates back to this idea that, we were not thinking about how do people react to policies and what is the downstream impact of policies on other aspects of livelihood. So models of infectious disease traditionally are based on epidemiology, not on human behavior and economics, but that's something we need to change to kind of bring these fields to better together. And it's something that a lot of groups, I think, are working on, certainly something that I have worked on in collaboration with economists to try to make frameworks to actually link these two types of dynamics, as have sort of other groups around the world. But if you think data is bad for epidemiological indicators, wait until you start thinking about behavioral indicators. We really don't have great data on sort of what decisions are people making, why, what's impacting that, and what is the impact on the daily lives of some of these changes. So this is a big kind of research and data challenge to bring these fields together, but we really do need this to make sort of policy predictions from models that actually take into account all the impacts of policies that matter, and we can't really separate these things anymore. So overall, I just want to leave you with these takeaways, that if we want better models to inform better policies, we must start with better data. Valuable data can be collected through passive surveillance, but we really also need purpose-designed epidemiological studies to collect some of this data. And the kind of creation, maintenance, and validation of these data systems and their integration into models is a key pandemic preparedness activity that cannot be left till the middle of an outbreak next time. So I just wanted to acknowledge some of the small subset of the many people I've worked with sort of over the COVID period that informed a lot of my thinking on this, a big modeling team at Hopkins and many of the other kind of modelers and economists that I've sort of worked with and got to think about many of these ideas over time. So happy to take any questions when we get to the Q&A period. I don't know if you'll be at the right place.
Okay, thank you, Alison. That was terrific. So next, I want to introduce Professor Jeffrey Siegel from the Department of Civil and Mineral Engineering and a member of the Hub for Advanced Buildings. His research interests include healthy and sustainable buildings, ventilation and indoor air quality in residential and commercial buildings, control of indoor particulate matter, the indoor microbiome, moisture interactions with indoor chemistry and biology. Welcome, Jeff.
All right, good morning, everyone. What I want to talk about today is about what I study, which is ventilation and filtration, and particularly the data associated with them. And what I want to do is kind of start from a retrospective, what we knew before the pandemic, what we learned during the pandemic, what we kind of ignored, and what we still need to know. So I think it's really important to start with definitions, because a lot of our challenges with filtration and ventilation is that we're not always using standard terminology. So when I say ventilation, I mean fresh air from outside, and when I say filtration, I mean air that is recirculated within a space but has been somehow treated to remove things from that air. It's really important, even though I love filtration and ventilation, could talk about them all day, that they are one in a long list of measures we might do in a public health emergency, and there's lots of caveats about them. So I always kind of have those on the slide as well. So if we start with what we knew about ventilation, for example, ventilation has been a strategy that has been used in public health emergencies for pretty much as long as we've had buildings. This is a review article from 20 years ago that shows for a variety of diseases, ventilation is beneficial. It will reduce transmission of those diseases. Obviously, this was long before SARS-CoV-2, but SARS-1 is on this list as well. So we know that ventilation can be very helpful for a variety of diseases. Filtration, there's a little bit less evidence and maybe different evidence, but there is plenty of evidence, both direct evidence that we generated during the pandemic for SARS-CoV-2 specifically, a variety of evidence on other diseases, as well as kind of basic physical evidence. Filters can remove particles that contain infectious disease from the air. And so, again, we had plenty of evidence that filtration should be in the toolkit. We also knew buildings were important. For those who don't recognize this picture, this is Amoy Gardens, which is a housing complex in Hong Kong. During SARS-1, there was one index case in Building E in this complex, and that spread to over 200 cases in this building. And other than being kind of tragic, it's a fascinating story from a scientific perspective, because it was kind of this confluence of different building design elements, as well as the things like the prevailing wind that led to this outcome. And if you don't know this story, you should Google it or read one of the articles like the one I cited here, because it shows how buildings can really amplify things. And then the last thing I want to talk about and kind of what we knew going in is what I call the 5-micron elephant in the room, and that's kind of the evidence about airborne transmission. And so, for as long as we've been able to take high-speed photographs, we've had pictures like this one here. This is a sneeze, showing that a sneeze and the droplets from a sneeze will propagate for 7 or 8 meters. And it turns out that all respiratory emissions kind of have properties like this. They propagate much further than we'd expect. And we know that not so much from looking at respiratory emissions, but we know that, for example, from looking at clouds. So if you've ever looked up at a cloud, and by the way, a cloud, most of the water droplets in a cloud are about 20 microns, so they're quite large. If you've ever wondered why a cloud doesn't sink to the ground, even with those big droplets in it, it's because it's surrounded by humid air. Water vapor is lighter than the surrounding air, and so that creates buoyancy, and this cloud stays as a coherent mass. And so, by looking up, we can see why things like, as I'm talking now, there is a cloud of respiratory droplets that are going much further than we would expect in the space, because it's moist, it's also warm. I don't spend a lot of time looking up. I spend a lot more time looking down, especially at things like dirty filters. But if you've ever changed the filter in your life, either a central filter or a portable filter, you'll note that it's covered with a lot of dust and big particles, things much, much bigger than a few microns, things millimeter scale or even bigger than that. And in order to get to the filter, those particles have to travel through the air. They have to often make several 90-degree bends and other things, and they still make it to the filter. And so if you've ever looked at a dirty filter, that's kind of proof that big particles can travel much longer distances than we expect. So we knew all that, and we've known all that for decades. We also learned some things during the pandemic. This is the first paper I know of that kind of evaluated whether filtration and ventilation made a difference to transmission of diseases. This was from 123 elementary schools in Georgia. All they did in this study was they asked the administrators, hey, did you do anything to improve ventilation, improve filtration, or both in your school? And then looked at the rate of COVID-19. And you can see that for either ventilation, filtration, or both, we have no idea the quality or anything about these measures, but on average, they reduce transmission. Later in the pandemic, we developed a lot more. There was more papers like the one I just put on the screen that show that, very specifically, this is from a school, a very large study where they looked at, for example, the panel A here is the difference between MERV 13, which are very good filters, and MERV 11, which are not quite as good, but still decent filters. And you can see there was a difference in the rate of transmission in classrooms that had the better filters. A little bit less evidence for ventilation, and that probably gets into some of the details about how ventilation actually happened in the spaces. But again, we had plenty of evidence during the pandemic. We also had evidence, like we saw in Amoy Gardens, that there was spread within buildings. So this is a paper from South Korea where there was a vertical incidence of cases within this tower. And through security camera footage, they could rule out people coming in contact with each other. And so this was transmission that happened in the building. And it happened because most buildings have vertical chases for plumbing and mechanical systems, and air can move through those chases, especially when there's an inside-outside temperature difference, and it can spread vertically. And we saw this in southern Ontario, in several locations, and throughout the world, that this can be important as a route of transmission. And then another thing that I think there was a lot of talk about in this community over time was misinformation. But there's a couple of kinds of misinformation that I think don't get enough attention that they should. So one is public health emergencies bring a lot of people out of the woodwork who are looking to sell solutions to that public health emergency. And in my world, that's a lot of companies that make air cleaning devices, many of which that either don't work very well or in some cases have kind of hazardous byproducts of their operation. So there was lots of headlines like this one here from a building using a device telling people it would be protective when in fact it wasn't. There was a bunch of lawsuits that were filed. The lawsuit that's listed here, which is still ongoing, is a company that made an air purifier, sued a journal that published an article, a scientific article about the device. And now it's up over $2 billion, kind of a little bit of Dr. Evil there. So that's one kind of misinformation that I think we should be thinking about when we're thinking about data and where data are coming from in public health emergencies. Another one is, we sometimes see misinformation coming from within. So you might remember the circles in parks that were keeping people 2 meters apart early in the pandemic. Like, this has zero science, zero data behind it. And even 2 meters distancing inside has no evidence behind it to support it as safe. Basically, as far apart as possible is what the evidence actually supports. And so I think we have to really think about data and how we're using data in the context. And then there's another aspect of data that I hope is part of the conversation today, and that is data are sometimes provided differently to different communities and different types of organizations. So for example, even as indoor air quality was kind of slow to be recognized as something that was important to think about in COVID-19, there was different information being provided to different types of buildings and so on, and that should be part of the conversation. So I think there's lots of reasons we potentially ignored these evidence. These are all things that have come out in my conversation with others about why we didn't use ventilation and filtration. There's lots of kind of domain issues, what people know, what they're used to, what they study. There is a lot of other things here. I'm not going to go through all of these, but I want to make kind of two observations. The first one is that, we have a lot of data out there to address some of these questions. As one example, this is a paper, a lead authored by Alex Mendel, who was a PhD student. He graduated at the end of last year. And he just went through the data on people who had published studies about portable air cleaners and understand the extent to which how those air cleaners were used, the context in which they were used in, how they influenced their performance. And I think that we have a lot of times information that's important metadata that we're not considering. The other observation I'll make about this list is these are not about data, by and large. The last one, the lack of randomized control trials for ventilation and filtration, that's potentially the only one on this list that actually involves data or needed data. So I think there is a really important question here about whether data is or are the limitation for addressing some of the issues in pandemics. So I want to finish up here by talking about what I see as some of the needs around data, especially in the context of filtration and ventilation. The first thing I think we need to ask ourselves is the lack of data the barrier here? In many cases we have data, or in many cases the lack of data is not why we're not seeing action. And so I think reflecting on whether we actually need data is important. And the other thing is that some data is very expensive to collect. An example would be a randomized control trial on something like ventilation or filtration would cost a lot of money. And I'm always thinking we have enough evidence to deploy these things, and would it make more sense to do that deploying rather than trying to collect data, especially in the context of data might not be the barrier. Another really important data need we have is understanding indoor environments where many public health emergencies kind of tend to multiply. There's about 16 million buildings in Canada. Over 15 million of those are residential buildings. The rest are a variety of residential, commercial and institutional and industrial buildings. We know almost nothing about all of those buildings from the perspective of deploying ventilation and filtration in a public health emergency. So I'm a big advocate for, I just did my census form yesterday, so I was thinking about this, doing a census of buildings so that we know what's possible and perhaps where to target measures. And just to make that a little bit more concrete, this is an example of if you live in a tall multifamily building, you might be used to seeing something like this. Some buildings have an access in each of the bathrooms to the central plumbing stack for the building. That central plumbing stack is what I call an air superhighway between units in a building. And so, whether that door is gasketed, the nature, how that plumbing stack is designed is really important. And this came up, there was an outbreak in a tall building in Ontario, and I was part of a group that was trying to kind of understand what was going on. And about an hour into our first conversation, someone mentioned that, oh, yeah, there are all these, panel access doors in the bathrooms. It's like, why are we talking about anything else? That's probably an important target for us to be thinking about. So when I say a census of buildings, I'm saying like very simple stuff to collect like this. You don't need any expertise to understand if that exists. Another example I like to give is long-term care homes. The one question I would always ask of a long-term care home is there personnel on site who deal with the HVAC system? And the answer to that question, yes or no, determines a lot about outcomes in that long-term care home. So there's a lot of very simple stuff I think we need to understand. It could extend to schools and to other environments as well. And another important kind of context to think about in terms of data is, for the first time, there is an infection control standard. This is promulgated by ASHRAE, and it will, if you apply this standard, it will reduce the risk of airborne transmission by 95%. Having said that, even in a well-resourced place like U of T, essentially none of our classrooms could meet this standard without reducing occupancy dramatically. So, there's open questions about what we can do and so on with ventilation and filtration, but if we have data about buildings, we can start to think about things like this standard. And the last data need I want to talk about is thinking about how we might use these strategies better in public health emergencies. So the picture here is part of an intervention study that's being done by a PhD student, Zoe Hoskin, who's co-advised by Sarah Haynes and myself. And what Zoe's doing is she gave a bunch of people portable air cleaners, and then she's giving them an intervention on how to use those air cleaners and seeing if it changes their use of the air cleaners and, importantly, the concentration of particles in their homes from these spaces. And this kind of implementation science piece side of things, how we use these strategies, is really important and something that we haven't studied a lot. We also have opportunities to do things very, very differently than we have historically. So I'm involved in a project that's looking at tuberculosis, particularly drug-resistant tuberculosis in sub-Saharan Africa. And the part of the project I'm involved in is we're deploying portable air cleaners in certain wards in some hospitals. And we're using those portable air cleaners. We're evaluating how well they contribute to infection control, but we're also using them for surveillance of TB and some other things in these spaces. And this is the first air cleaner that's deployed in mainland hospital in Nigeria. And I think that this type of approach of, we heard a few things about wastewater surveillance much earlier. I think there's an opportunity here to think about using our filters for surveillance on a much more micro level. And I'll finish there. Thanks.
Thanks, Jeff. That was terrific. So next I want to introduce Dr. Mina Tadrous, a professor in the Leslie Dan Faculty of Pharmacy. He's a licensed physician and pharmacoepidemiologist. He leads research in the faculty's Clinical, Social, and Administrative Pharmaceutical Sciences Division using real-world evidence to improve how medications are used. He works with policymakers and large data sets to answer questions about medication and safety. Welcome, Mina.
Okay, awesome. All right, good morning, everybody. Thank you very much for having me. I am a pharmacist who likes data, so this is a real pleasure to be here and talk about this, especially to a bunch of public health folks. I'm also a pharmacoepidemiologist, which is like the forgotten stepsister, brother of epidemiology. We do exist, but we like to count things and count drugs. Before I start, I often like to kind of start with a tally here. Who here has been affected or knows somebody who's been affected by a drug shortage? Yeah, so that's about right. So 1 in 4 Canadians, based on a recent survey, will in the next 2 years be affected by a drug shortage of some sort. And that was done before the pandemic and before we had the massive children's Tylenol shortage, which really kind of changed the game on things. And that's what I want to talk to you about today. Before we jump in, I think some important disclosures. A lot of the work I'm going to be presenting today has been funded or has been supported by various different of work. I have done work related to shortages with the Canadian Pharmacists Association, Canada's Drug Agency, Health Canada, Green Shield Canada, CSHP, the US AHRQ, also ICED. And some of the work I'm presenting today is actually under patent review and is an invention filed with the University of Toronto with a commercialization happening within the university. So just so we could get ahead of that. So drug shortages are an interesting and important problem. And I think one of the challenges with it as a pharmacist and what we dealt with is that they feel like they come out of nowhere. And this has been a problem that's been ongoing for the last 20 years. This was not a COVID-19 problem. It was a problem that has existed and continued to get worse over the past 2 decades. And importantly, one of the real challenges with it is that they feel like they come out of nowhere and that each one is unique in the way it presents. Sometimes it's a shortage of a specific product, sometimes it's a product line, sometimes it's a specific formulation. And for clinicians, this is super challenging because you go from a situation where everything is humming in a certain way and you're used to prescribing something, and suddenly you have to pivot and switch to them. And the real challenge is that mostly we felt very powerless. Everything can just happen at any single time. And I think it's important to recognize some of the background work and like what's the background story of what's happening in this way. So first, let's start with some definitions. So, there's a variety of different definitions that come from Health Canada, the FDA, the ASHP. But generally, to me, the most important thing about drug shortages is that there's a patient in the pharmacy or in a hospital bed, and I am unable to get them the medications that they need. And this seems like a nuance, but it's really important because actually for a long time what held back this field was that very definition. Some people, manufacturers, would consider it a supply chain disruption if there was a report, but actually it's the importance of being able to not have the supply needed to meet the demand in that situation. So drug shortages are an important concern. So 1 in 4 Canadians, like we talked about, have experienced a drug shortage in a specific survey that was done right prior to the pandemic. In Canada, on average, we have 2,000 to 3,000 active shortage supply chain disruptions a year. And this is where I want to note something that's really important. One of the main problems is that we live in an era of plethora. We have so many drugs and therapeutic options. And for that reason, the complexity behind these supply chains has gotten worse and worse, and things can actually break apart and go in different directions. And if you look at it at the drug formulation level, the FDA gives us the best clue about it, but we can have about 100 active shortages at a specific time out of 1,400 products. So you can have a time period where you have like 1 in 15, 1 in 20 drugs that are affected in some sort of way. And one of the biggest issues when we started doing this work in about 2015, 2016, is that a lot of the research was all based on supply chain reports. So I just, for this audience, I just want to, so supply chain reports means that you have a product and the manufacturer raises their hands and says, we have something going on in the supply chain. It doesn't mean, so as a pharmacist, I could still log in and I can still order the drug from my wholesaler. A shortage is when I log in and I can't get that thing. But yet we had very little insights into what was happening. All we had is these reports, and what our research found is 9 out of 10 times these reports actually were meaningless because I could log in and still get the product for people in the way that they were. And why is it such a complicated problem? So this is actually a simplified framework of what a supply chain looks like. And you can kind of see here, if you can't see it, that's by design. You can see here that this starts with APIs. So APIs are the active pharmaceutical ingredient, and it flows to who makes the tablet or the capsule, the pre-packaging, that goes to a wholesaler, that goes to a hospital, gets distributed, And the same is true for vaccines, devices, and you can kind of simplify it in this manner. What's really complicated is that this can happen over countries and continents. There was a recently really neat analysis that looked at clonazepam and said, how many countries from the raw ingredient to the shelf in a pharmacy in British Columbia did you think it went through? How many countries would you guess? Take a stab at it, you won't. 6? Go a little bit higher. A little lower. 9. 9 countries. right, from everything that went in. And that's to the best of our knowledge. And that took like an investigative journalist to figure out all of those pieces. And this is all opaque, because a lot of this stuff is business secrets. And they don't have to tell you exactly where it comes from. And I think that's sort of the opaqueness that allows us to be an issue. So why do they actually happen? And there's a variety of reasons that they can happen. So manufacturing breakdowns are a huge concern about where things go wrong. For example, some of the worst shortages we saw in hospitals were in 2017, where we saw two manufacturers merge, and there was a huge issue with IV injectables in the way that they were distributed, in the way that they work. This caused a shortage of critical sterile injections, which for hospitals is detrimental to the way that they deliver services. We also know that crises globally can happen, and a really interesting point about this that we learned was in Hurricane Maria when it hit Puerto Rico, which was devastating to the island of Puerto Rico. But little did we realize that for the Western Hemisphere, Puerto Rico is the largest hub for IV production and biologic production for a lot of tax reasons. And so we saw massive shortages. And I think we saw this very recently when a certain strait got closed, and suddenly supply chains started to buckle in a lot of different ways, right? We learned more about helium, which 20% of it comes from Qatar, and everyone became like a supply chain expert in a second around there. And you can imagine, like, this is random, right? A hurricane, a tornado, and as these events continue to climb up in a turbulent time, it becomes more and more important. And lastly, recalls. Sometimes there's manufacturing hiccups, things can happen, and we see entire product lines move away. And what we also started to realize is that not every shortage is the exact same. So every shortage can hit, but its clinical consequences, its system level consequences, and the cost of them vary massively. I'll just paint a picture for you. So there was a really great JAMA paper that looked at a norepinephrine shortage that hit hospitals. This shortage, punchline, increased mortality. Like, people died because we had to use an inferior product to this in the ICUs, and that's what they were actually able to show. In contrast, we had a really big global shortage of valsartan. Valsartan is a blood pressure medication commonly used across diabetic patients and a lot of people living with heart disease, a real pain in the ass. We estimate that about 200,000 Canadians in a single month had to switch, massive implications. But we've studied this in the US and Canada, heart failure, you name every subpopulation, no one died. Because there's therapeutic alternatives. We were able to switch people, it's a preventative treatment. So the size of the shortage and the drug matters. Not every shortage hits the exact same. And there's also behavior, and we've heard this from the other speakers as well, of unintended consequences. So this figure's from some colleagues here in Toronto who looked at poison control calls after the children's Tylenol shortage. And what we see is a massive spike as parents who were desperate started to try to compound their own Tylenol. But also implicated is the system level impacts. I just highlighted this. So 200,000 people going to get refills in an already stretched healthcare system can have huge implications on the strain of our system. These are 200,000 faxes going between doctors and pharmacies. Yes, we still use faxes. It's really annoying. And this is how it works. So this was all, before the pandemic. And we kept working at it and chipping away and trying to better understand. And we had this vision of, like, could we help people make decisions? And when the pandemic hit, we learned a lot of important lessons. We actually established a monitoring system, and we started to watch drug supply and vaccines and things like that happen. And we learned some really interesting things. The first is that when you place a policy on supply, it'll move, right? So we started to try to limit the number of prescriptions. If you remember, they gave 30-day scripts, so it went up. The second thing is, and we all know this, consumers and people will react a certain way. I call this toilet paper syndrome. And, I think what we saw is even tweets of hydroxychloroquine and its potential benefits saw massive spikes in its use, and it actually led to some shortages, and India sort of stopped exporting some of its hydroxychloroquine. Funny enough, we did an analysis of purchasing of drugs comparing tweets to the publication of meta-analysis, and which one do you think had the biggest impact on drug utilization? Yes, unfortunately not the meta-analysis. The tweets are superior in moving the dial on drug purchases. And then lastly, it's not just patients, it's systems that have behaviors. And so salbutamol, so the blue inhalers that are rescue inhalers, in the beginning of the pandemic, if you remember, we didn't know how big of a respiratory issue this was gonna be. Asthma patients and patients living with COPD rushed to get refills of their inhalers. But that's because the hospitals wanted to switch away from nebulized formulations. And so the hospital started purchasing all the inhalers to the point where we had a shortage. We had to bring in drugs from Poland that were labeled in Polish so that we can get enough inhalers in the place. So not just people, but systems that are actually there. So around that time, we see that there's a lot of impact on shortages. And I hope I've sold you on why this is important and why we care about it. But the world started acting in a particular way, and one of the things that they wanted to do is better understand what drugs are most critical and what should we be doing. So we saw an emergence of people making drug lists. And this really peeved me because what was happening is what they would do is they'd bring a bunch of people into a room and they would say, what drug is the most important? And this sounds like a fun party game for a bunch of pharmacists. But I make the joke that if a dermatologist snuck into a room, and I'm sorry if there's a dermatologist in here, but that there's no way that you're gonna leave that room without a cream being on that list. And if you ask anybody, they're always gonna, it's like these lists have a natural way of ballooning and they grow and grow and grow. And that's because we don't have systematic ways to look at them. And the moment you create a list, it's instantly out of date the moment you walk out of that room. And that's what we propose to actually fix. We wanted a list, and we said that any list that produced should meet 4 tenets. It should be systematic in the way that it's produced. It should be adaptable. It should be transparent so that people trust what's going into it, and it should be updatable because the data moves and so does the supply chain. And that's what our research set out to do. And we also thought for a drug, you should care about 2 things, not just one thing. You should care about the supply chain risk. We can actually predict, based on the characteristics of a drug, what's most likely to happen. And every drug is not clinically the same, so we can actually score the drugs and think about what's most clinically important. And so we produced what we call a policy agnostic tool that can be used in a variety of different functions in the way that they are. And what it aims to do is sort of take that supply chain figure that I showed you before and sort of see what characteristics and where we can think about them. And based on all these characteristics, can we actually think about the demand factors and the way they work? And from a data perspective, how we sort of did this is that we treated every drug like a person, and we actually created a repeated cross-sectional cohort study. So we followed them forward using drug utilization purposes. We matched drugs that had a supply chain issues versus not. We developed a validated outcome, which was the first of its kind to be done, which is based on real purchases. So this was the first time that someone had said, I want to see what happens when there's no drug in the system, and we defined it as a 33% drop in wholesale purchases in the entire country. We matched them together, and we followed it forward, and then we reverse scored them. And we had to merge 10 different data sources together to be able to understand the characteristics. So this is analogous to developing a cardiovascular risk score. So this is bleak, but the same way that you can predict who's most likely to have a heart attack, they may not, right? They can have all the risk factors and never have a heart attack. We can do the same thing for drugs. We can say if they have certain risk factors, in the next year, they are very likely to have an actual shortage. And then what we got is clinicians to actually score the drugs and tell us what was most important. And then based on that, we can then categorize drugs. So what would percolate to the top would be drugs with the highest probability of a shortage and those with the highest clinical importance in the way that they do that. And what was really exciting is that as we developed this tool, Health Canada was starting to get the mandate to build a list. And actually, just a month ago, on April 2nd, 2026, Health Canada announced the release of a critical vulnerable drug list, which is actually based on our tool and the work that they did. It wasn't a copy of the list, and I'm happy to talk about what that process looks like, but it fed right into the development of their list. And then we built out this kind of algorithmic process, and this is the dashboard that we're able to do that updates monthly with live data, and we realized that the system needed this from everyone who procures drugs to people who are responding to drugs. But little did we realize what was about to come our way, that this became even more important. So as tariffs and impacts on the system switched from a pandemic crisis to a health system and supply chain crisis, we started to realize that there was a real important need for this sort of data to fill those gaps. this is all really important, and I think what this crisis has shown us is my closing points about what data, we learned that we can piecemeal a lot of data to get pieces together, but then there's some important things that we knew that we did not have, and I think this is where I want to close off. One, within the supply chain, we actually don't have a clue how much drug is inside the country at one single time. We don't know where it is. There's countries that can pinpoint at the exact warehouse where a product is. I'm not even asking for that. I just want to know how many capsules or vials of a drug we have inside our country, and we don't actually have that ability. Even more important, we don't actually know where most products are made. And like I pointed out in the supply chain piece, like those APIs and the excipients that go into it become very important when you have a war, you have a crisis that's breaking down, and you have tariffs and geopolitical issues. And this is going to continue to be a problem. I think we can all recognize that we are in a special era now. And so how do we get better insights into what's happening in that space? And I think that's the data that we start to need to better understand to improve on the work that we've been doing in these supply chains. So thank you again for your time, and happy to answer questions later on.
Okay, thanks again, Mina. I get the opportunity to go last, and then we're going to call up our panelists for questions. So I'm going to go a little bit faster because we are a little bit behind schedule today. So I'm an internist at St. Michael's Hospital and a Canada Research Chair at University of Toronto focused on healthcare data. And I'm going to tell you a bit about our platform, which was able to provide some supportive information during the pandemic, but importantly, I want to highlight where it was not able to provide the information we needed and where we need to go. So just as a starting point, for healthcare encounters in the system, and I'm going to focus on hospitals, which are often a critical point in crisis response, whether it's pandemics or wildfires. Historically in Canada, we've had a few 50 to 100 data points that are manually generated. So if a patient's admitted to hospital, there's a coding department which then takes the chart at the end of the admission. They fill out some fields and they send it to the Canadian Institute for Health Information, or CIHI, which is our national repository. But the opportunity now for harnessing data has changed dramatically, and I would say the last 15 years has seen an unbelievable pace of digitization in the system, so that now every encounter in the system is generating hundreds of thousands, if not millions of data points just to provide routine care. So what is that data? It's things like thousands of words of text about patients who are being admitted. It's digital vital signs, it's transfusion information and other blood products, imaging, and even the raw imaging data itself, which if you count that, that's millions of data points per patient that's admitted. The medication that's given, blood and other testing, details on physicians, and operational data. So that data is now 99% or more of all data that's generated just as part of routine care. And harnessing that data has enormous value for analytics, for trials, for artificial intelligence, and importantly, as I'm going to highlight, for crisis response. Our group has worked a lot on the bioinformatics of how to extract that information at scale. A province like Ontario is a technical challenge because hospitals that are across the street from each other on University Avenue can use completely different data systems. And so a lot of the work is pulling from the back ends and ensuring that it's high quality. I just want to say that you can do that now using a series of AI approaches and other statistical approaches. This is an audit of just over 23,000 randomly selected data points, the lab tests, the imaging data, the vital signs, all of that, where you then send someone back into the hospital to audit and see against the medical record, does all of this extraction actually match what's in there? And the answer is it can match it with very high accuracy. So you can see ranging from 98 to 100%. So that data, as we enter the pandemic, was in our platform. We're a public sector group called Gemini, not to be confused with Google Gemini, was already covering about 25% of all of Canada's beds, or about 60% of the beds here in Ontario, including adult admissions, ICU admissions, many billions of data points, and was already supporting a big ecosystem of users. And when the pandemic hit, we didn't know this platform, we didn't build this platform knowing a crisis was coming. It ended up being able to output things that were valuable in terms of understanding what was happening in the pandemic. So, for example, within the first year of the pandemic, there was a question about whether the infections were just of the flu, nothing more severe than the flu. And that's what was being said in the media and by some politicians. We were able to provide Canada's first and largest study of COVID hospitalizations, and we showed actually, based on 5 years of historical data, that it had tripled the mortality of a typical flu admission. We showed the resource utilization was high. We were able to develop triage scores. So this is one example of being able to pivot to respond to what was now flooding into the system. A second example, drug shortages. So working with key leaders like Mina, we started to worry about drug shortages, and one of them was tocilizumab. So by good fortune, the first life-saving drug for COVID that was found was a steroid, widely available. But the second drug was this, an IL-6 inhibitor, very scant supply chain, used historically for rare malignancy-related complications. I think at that point, Mina can correct me when we get to the panel, but I think there was only a single global manufacturer of that drug, and we knew we were going to run out. So we were able to quantify what that shortage would look like, develop a triaging approach that was then adopted here in Ontario, which practically, clinically, I was also on the front lines admitting patients to hospital. This is how we started to triage the drug. Again, harnessing healthcare data sets that were not designed for a crisis, but you can see how they can pivot to provide important and useful information. Third example is vulnerable groups. So this is a CMAJ patient portrait of a patient at St. Michael's, Victor Pereira. And we worried about patients like Victor because we knew that for patients with disability, when they were admitted to hospital, what we would traditionally see as a visitor was often more than just a visitor. It was a critical caregiver. So for a patient with intellectual disability, speech impediments, physical disability, that person visiting often provided critical advocacy, helped with nutrition, helped with personal care. So as hospitals were shutting down visitor access to hospitals as the pandemic was ramping up, we worried that patients like Victor would be disproportionately impacted, and in fact we showed that. So this was the first large study of patients with disability, and it showed that independent of the disability, they ended up doing much worse in hospital during that period, and it led to changes in policy at some hospitals that they relaxed those visitor policies. For example, with a patient with disability, they allowed one critical person to come into hospital. Okay, so let me go back to that first paper, the one that described COVID hospitalizations, and tell you why it was not an important paper. So it was published in March of 2021. So I saw Helen was here earlier, people like Helen, people like Brian, they were not allowed to wait a year and a half to make decisions about the severity of COVID. They had to make decisions in the moment. They had to make decisions a year earlier in March of 2020 as these cases were flooding into the hospital. So even though we were the fastest capacity in the country to produce this kind of output, we were so far behind real time that it was just academically interesting, but not policy actionable. Let me contrast that to what was possible already in the world at that time. So this is an example from Israel. And Israel had, at that time, 4 large electronic health records that could be harnessed in near real time to evaluate the impact of infections, of medications, and other important questions. And this was the question around how effective is the mRNA vaccine. So the mRNA vaccine, as you know, from I think history, we'll see it as one of the pinnacle developments in human science, less than a year from the emergence of the virus to the development of this vaccine. But the testing was done on a few thousand people in each of these trials. We didn't know at population scale how effective this vaccine was going to be. So Israel stepped forward and they offered a partnership with Pfizer to use their electronic health records to provide population-wide evaluation of these vaccines as they were being rolled out. And so this was an evaluation of nearly 600,000 people that was produced about this mRNA vaccine. It also meant, importantly, that the country had preferential access to the vaccine. So as the rest of the world was scrambling to get access to the vaccine at the end of 2020, Israel, the Jewish population of Israel had tripled the vaccination rate of the next highest country globally. So you can see both they led the pivotal science, but also the population benefited enormously because they were able to do this science. So what did this mean? So the vaccine rollout commenced in December 19, 2020. They sent an evaluation period of 3 months, so this is December 20th to February 1st, 2021, and they produced this publication in the New England Journal of Medicine by February 24th of 2021. That is a 3-week window from the end of the rollout of a 600,000 person vaccination campaign to analysis, writing the paper, submitting it, completing peer review, and having it published. So that's how fast they were able to do it versus us, which was the best in Canada capacity, to answer a much simpler question, which took 15 months to do. And so that highlights why our existing capacity was not up to best global standards. So if you look at Gemini, we are a single province. There was not similar capacity across the rest of the country. Our data lagged real time by on average 9 to 12 months. We didn't have governance for certain vulnerable groups to have analysis that focused on impact. So for example, we hold a lot of Indigenous data, but there wasn't inbuilt governance around Indigenous populations for the data. And then we had no mechanism to work with, for example, a Pfizer to do that evaluation. So let's say that our data was even fast enough to do this here in Canada. If Pfizer had stepped forward and said, we want to work with you, our governance and legal structures here would not have allowed us to do that partnership. These are the scale of investments that are happening globally to answer this kind of question. So these are investments in health data that can be rapidly harnessed for innovation applications. To be very clear, this is not about healthcare delivery. It's about things like crisis response, supply chain disruption, trials, artificial intelligence. And historically, there had not been that scale of investment yet in Canada. And if you think specifically about national defense, resilience, pandemics, crisis, the way that you could use this data, I highlighted pandemic response, but supply chain disruption is also a very important area to look at. The tocilizumab example that I gave, acute care capacity and patient transfers. I'm gonna give you a little bit more information about that in a second. Our blood supply, so our blood supply is always on a precipice. We are sometimes within weeks of running out of certain critical blood products in the country. The ability to track that at scale today, there isn't an ability to do that in Canada. The quality of care that's being delivered, patients like Victor, the impact on vulnerable groups during a crisis, medical countermeasures and trials, the example that I gave of Pfizer and the evaluation of the mRNA vaccine, and then importantly, AI development and the use of this data now in ways that I don't think we could have really imagined at the start of the pandemic. So let me talk about acute care capacity just in a little more detail to put some color on this. So as you know, and I think a lot of the leaders of this are in this room today, we had the largest patient transfer in Ontario, if not Canadian history, during the pandemic. Acutely ill patients were transferred between hospitals, I think nearly 5,000 in total. And this was done because the impact of the pandemic was very uneven. So you had communities where there were frontline, racialized and other workers, the Amazon plants, the hospitals near them. There was huge surges of admissions into those hospitals. There were other hospitals like us here in downtown Toronto, St. Michael's, where we still had excess capacity. And so there was a need to transfer patients. We were looking at places like Italy and New York State where the collapse of the hospital sector under that influx was this critical problem that resulted in kind of mass mortality. So what happened practically was physicians, healthcare leaders, and others within these hospitals and within the ministry sat down on a daily basis and they manually went through lists of patients. They circled, they said, we're gonna transfer. And it was all done by just looking and making that decision on an individual patient basis. This is coverage of that period. I think this will bring back memories again for many in the room who led that response. So this preserved our system. This allowed us to continue to function. But again, think about that. 16 million people, we did this by hand. We didn't use anything further beyond circling and deciding which patient to move, and we did this for thousands of patients. So this was a really interesting opportunity to ask what would happen if we had the data to make this decision rather than doing it by hand. If we had the ability to run simple optimization algorithms like a queuing network to say, okay, we know not just that we have a patient to transfer, how old are they, what's their expected deterioration rate, how long would they be on ventilator, where's the discharge, where's home, all of these other things to optimize simultaneously and to run that optimization across the entire system, across all patients admitted to hospital. So we did this. We took Gemini data and we worked with partners at the ministry and we worked with simulation experts here at the University of Toronto, and we ran optimization to say, if we had this data at the time the decisions were made, what could we have achieved? And the answer is, we probably could have increased capacity within Ontario by at least 20 to 30% within acute care. So that just gives you a sense of what would have been possible. We didn't have the data in real time. Okay, I just want to finally add some equity-related issues here. We know that when pandemics like this hit or crises, that there's going to be wildly unequal impact on populations. We know that those who get access to innovation and countermeasure trials and other applications tend to be those in bigger cities. They tend to be healthier, they tend to be younger, they tend to have higher education, and so on and so on. The digital data that's being used suggests that it doesn't have to be this way in the next crisis. So let me give you an example in the United Kingdom. This is not a crisis. This was a cancer-related trial that was run across the population. They used the data to find every eligible person in the country. So there's a National Health Service. So they found, in this case for early cancer screening, every person that could be eligible for the trial. So again, now think about a crisis. If we have a new vaccine or a medical countermeasure that's developed, we know that disproportionately we're going to be deploying that on University Avenue at St. Michael's Hospital, but patients in other places in the country are probably not going to have access. I'm just going to push ahead to also say that the other part of the equity in the response is knowing where the gaps are occurring and responding in a time frame that allows you to do something about it. So we often have documented here in the province pretty significant socioeconomic or race ethnicity disparities in the way that outcomes happen. Of course, this is not just a Canadian problem, this happens all over the world. Here's an example in the United States where the life expectancy of American Indian Alaska Natives dropped by about 6 years, so the largest documented drop in US history during the first 2 years of the pandemic. But the publication to show that, again, was 2 years lagged. So this gives another example where the data lags mean you see this problem, you say it's dramatic, oh, but this is terrible, but you don't see it in a way that allows you to act on it as it's occurring. Okay, so with that, just excited to share that there's going to be some advanced capacity to do this here in Canada. So we were grateful to receive this investment to advance capacity, to bring us closer to real time, to enhance population coverage, and to meet a lot of the demands and gaps that I highlighted from our crisis response. So you could consider this investment to be the 2.0 version of Gemini. It's called the Vital Platform. We'll be building it here at the University of Toronto in partnership with people in Alberta and Quebec. It'll extend this kind of coverage, I'll take you along the bottom line, to 20 million patients, so roughly 50% of the Canadian population, with data lags that are less than 24 hours behind real time. So again, really important for the response. Bringing in, I'll take you along the middle line, so bringing in raw imaging data, which is an important part of how one of the most important early questions in the pandemic. Indigenous governance, so item number 4. And then item number 6 and 7, just to quickly highlight, better ability to do medical countermeasure trials and other capacities here in Canada. So again, using that example of Pfizer in Israel or Sanofi in Denmark, and governance, hopefully a governance advance that allows us to work collectively across provinces and in partnership with the private sector when that is an approved use. So for example, doing a medical countermeasure trial here in Canada so it doesn't go to other countries so we get first access. Okay, I'll stop there. So I'm going to call up our panel. Thank you. So Alison, Mina, Jeff. Because we've run over time this morning, I think I'm going to, if it's okay with Ted and Nelson, I'll pivot right to audience questions to give people a chance. Yeah, sounds good. Okay, welcome.
I thank you all. I have a number of questions which I will get to later, but for now I want to go back to the really interesting case of Israel's vaccination campaign in contrast with our own, because there's a kind of insight we can get in response to our keynote presentation this morning about effective and inclusive messaging, right? So, I mean, Israel communicated very openly uncertainty around vaccines and what they're going to do in their conversation, and it was a conversation with the public who were brought in as partners. They said, here's what we know, here's what we don't know, here's what we're working on. And it's a stark contrast to us, where we had vaccines are safe and effective, and then the science is evolving, more metaphors and statements that overreached in various ways. And you mentioned the stats, so Israel's numbers on the 2-dose regimen were the highest in the world, they're very close to it, although the UK and other countries did very well as well. But their booster uptake was huge, whereas here in Canada, we were talking about this earlier, our booster uptake the numbers were sad, or they were down to seasonal flu levels, right? So it's kind of the legacy of messaging that wasn't effective and wasn't inclusive, right? And we'll get some conversation around this afternoon, hopefully.
Yeah, I completely
It's not
agree.
really a question here, but if anybody has comments, that'd be great.
Yeah, I think it's a great comment from Brian. Does anyone want to address that? I think there's a lot more than just data. I think, Alison, you had mentioned some of this too. It's public perception of the use of data and what happens next.
Yeah, I mean, I think that there's multiple lessons to be learned from that, as you kind of alluded to. I think it's a great example of having this system set up that you can really do science in real time and get those key parameters that you need to understand what the intervention's doing and, make larger projections. But yeah, also at the idea of addressing uncertainty, I think that's just such an important thing for us to always be talking about. How can we improve that? I think you're right that there are many situations where we acted maybe like we had a bit more confidence in something than we did with, like, under the auspices of simplifying the message, which is sometimes important. But I do think there's a lot of examples like where that kind of backfired, and hitting the right note there in the future, I think, is just something to think super carefully about. I mean, it came up a lot in like the modeling and the estimating epidemiological parameters and saying, like, how confident are we in these projections that we're making, and what's the actual source of uncertainty? And from my point of view, the way, like, I think a solution to that is identifying what are the things we were uncertain about in COVID that, then led to this mistrust when we were wrong, and how can we narrow the timeline in the future to reduce that uncertainty? So if there's something we didn't know about vaccines, or about which age group was most important for transmission, or what is actually the incubation period, or how long are people infectious, like, if we don't know those things, what is the study that we could design now? What is the data we would need to get? How could we do that as quickly as possible so that we can more quickly know the right answer next time? That's one approach. I'm not a communication scientist. I'm thinking about the numbers, so that's how I would try to address that issue.
Howard.
So first of all, excellent presentations by all of you. So lots that I think we've all learned. I have a quick question, or maybe something to think about for each of you. So in terms of the modeling, I imagine, Alison, you probably know Nick Ogden from our agency. He and colleagues, obviously, like you across the country, did a lot of work with modeling. So maybe a quick question, if you could maybe speak to, like, when you put all of this, the data into your models, right? There's a whole question of sort of almost philosophical. What is the proportion, relative importance of the various types of inputs, right? You could have like morbidity data, or you could have other elements go in there. So maybe we speak about, like, how do you determine, is it like a group consensus in terms of how various modelers might want to use the different inputs, to what degree, et cetera? And then, of course, the communications aspect. I still remember some of the pressers we had to do, where sometimes, based on modeling, so, if you don't do something now, like, change our behaviors or whatever, it'll go up like a rocket ship. And then, of course, that creates all this fuss, et cetera. So that's one. In terms of the ventilation, yes, we've all sort of lived through the whole issue with aerosols and so on. So I'm going to ask you, in terms of what might be your viewpoint in terms of the international level discussions or politics, because I know WHO also, you're probably well aware of the committee discussions they had about infectious diseases, and there's even, a prominent Canadian, John Connolly, right, he was part of those discussions in terms of the back and forth. How do you see, in terms of trying to have the two different worlds, in terms of sort of the HVAC or whatever specialists in that field versus, quote, the infection control specialists, and how can we sort of bridge that maybe sort of paradigm difference, et cetera, and so on? And then finally, for Mina, I guess maybe it's more a philosophical question as well. It's right, in terms of global supply chains, et cetera. But I think in some ways you're looking at drugs in which, there's a need, but also because of the market and the money, et cetera. So we all get why there might be issues in terms of heart disease drugs, right? But what's your thought about, the fact that, orphan drugs, right, for rare diseases, there's always going to be a global supply chain because there's not the market, et cetera, and so on, the profit margin. And on the other side, there's the issue of, okay, why is it that we have shortages of drugs that, aren't developed because it's not cost of whatever for the, like, antibiotics, and the other ones being, say, okay, so why is the drug companies, I'm being a bit sort of sarcastic, are always trying to develop the next Viagra versus an effective TB or malaria drug? Because in terms of the global need, that's much more important. So there you go.
Thanks,
So-
Howard. Maybe Jeff? Yeah. go
Yeah,
ahead.
so I'll just very quickly say, I think it's the age-old question of who's sitting at the table when the decisions are made, right? And I think from the international context, we can learn a lot from other places. So for example, outbreak investigations in a lot of places, I'll cite Hong Kong, as an example, include someone with buildings expertise at the beginning of the outbreak investigation. Sometimes the building isn't important, and then that person can move on to other things. Other times it is important, and they're there. But if they're not even there at the table at the beginning, we're done. Another example I'll cite is that very early on in the pandemic, I wrote a little thing about filters and how filters might help us. And I asked several people around the world to review it. And one of my collaborators in China looked at it and said, we're already, our local hospital put out a call for people to bring in their air filters to use in waiting rooms and other spaces. So there was already acceptance. This was March of 2020. And so, I think that we can learn a lot from others and what others have done.
Mina?
Yeah, it's a really important question. I think TB drugs have experienced a number of shortages over the last few years, and I think, one of the reasons we developed the tool the way we did is because there are policies that you can do for different factors, and this is what's actually the conversation right now. How much drug do we want to produce in Canada? How much do we want to make sure we hold a stockpile of? And there's a whole slew of different solutions that are there. And I think right now, I spoke at the HESA committee a few weeks ago about this idea of pharmaceutical sovereignty, which is the big debate right now. And what I said is that no country, even the United States, as much as their current leadership thinks that they can produce all of its own drugs. There's just too many drugs. It would be too costly. Building a plant costs $1 billion. You can imagine, there's thousands and thousands of drugs. It's a cool thing. And so we have to be targeted. We have to use data to help us make the right decisions in the right time. And that, as Canadians, is what we should be working towards, is which drugs are most critical to us, and then we can use the different levers in the very right way. And I just want to touch on one last thing, because maybe this is the right room to do that. One of the biggest risk factors for a drug is if it's an antibiotic or antiviral. And the reason is that we are horrendous at predicting when we're going to need those spikes, right? You can imagine, it comes at. And when I talk to manufacturers about how they predict how much drug, antibiotic to bring to the country, and this was the problem with children's Tylenol, by the way, they just use a 2-year purchasing average. And I think this is a huge place for improvement, and something that me and Nelson have been talking about and thinking about, can we try to make better models to at least order the right amount of antibiotics, because they're constantly, being an antibiotic or an anti-infective is a huge risk factor for shortages. Just plugging that to the room if maybe the right person hears that.
I think we're right at lunch. Do you want us to wrap or go a little bit longer? One more question? Anyone want to take the last one? Yeah.
Thank you. Thank you, everybody. I really enjoyed all of those presentations. I'm Wendy Porch. I'm the Executive Director at the Centre for Independent Living in Toronto. We primarily support and serve people with physical disabilities. And I'll be talking a little bit about our work this afternoon. But one of the populations, the key population that we serve, disabled people, we could not see represented in data sets throughout the pandemic. And so we were in this position of being on the front line of seeing our communities being very impacted and seeing very little analysis or data for us to be able to prove that to decision makers. And I just wondered, generally, if there were any thoughts or responses on how we could do better at making sure that this vulnerable population is actually represented.
Any thoughts? Alison, I think you highlighted the need for some kinds of data to be built in proactively.
Yeah, absolutely. Like I was highlighting, I think, infectious diseases do not affect everyone equally, and it's really hard to incorporate that into models, and especially ones that are used for kind of allocating resources if we don't know that information. And I think part of the problem is that we don't always know in advance which sort of set of factors are going to make someone more at risk for, catching infection or bad outcomes with a particular disease until that disease starts spreading. So it's hard to say, we will just collect data based on race or ethnicity or something, that's not always a very good predictor. So I think we need to find a way, and I think one great thing about having these massive clinical databases is that we have a lot of information on people, and then early on in an outbreak, we can really figure out, what is the group that is more at risk, and then, make sure that we're working on that. But we can't always define it in advance, so we really need like a large swath of information, I think that's being collected and that someone has access to try to figure out what are those groups.
Jeff or Mina, any additional thoughts? I'm happy to offer just a couple of thoughts on this, which is that you saw that I shared a paper about people with disability. It's a highly imperfect measure that we used, and I think that a lot of the work to improve these measures needs to be done now. Canada is behind in measuring critical sociodemographic, race, ethnicity, vulnerability factors like things like disability. And I think we are starting to shift out of the norm in our inability to have this. So for example, I showed that graph of life expectancy drops in Native American and Alaskan Indian populations. We know that when the pandemic hit here, it disproportionately affected racialized communities, frontline workers, those things overlapped. But you have not seen a similar plot like that for Canada because at scale, we don't measure race ethnicity. And so all of us suspect you walk through the wards, you would see who is actually being admitted, but we can't show that at an analytic level. And I think the search for perfection in these terms, which are not perfectible, they are social constructs, there's a lot of complexity around them, the focus on that has hampered our ability to get meaningful insights that would reveal huge gaps and things that I think need to be acted on. So my feeling is we need to move forward on measures, imperfect as they are, get them better over time, and now is the time to do that, not waiting for a crisis.